Welcome to Suturing 101. So, this is my wound. What we're just going to go through is a simple intermittent suturing technique, which is the one that we use here at PHT most often. So you wash your hands, you get your suture kit out. Spin it up. I'm going to put my gloves on. What you want to do now is prepare the wound to be closed. We've got some sterile fields here. We have wound forceps with teeth, and then we have needle holders. You've got a set of scissors, and then you've got your clamp. So, first things first, we're going to make sure we clean the wound with some saline, which we're going to pop in here, squeeze it in there, and we're going to give the wound a little clean. We want to make sure we have a sterile field around our wound, so we're going to cut a little hole with our scissors. It just makes a sterile field so that you can put your instruments down without having to worry. So, there's my sterile field. And I've got my sutures. So this is a wound on the lower body, so I'm going to use 4O Dermalon. When you grab it, just make sure it's at this is the only time you'll be able to touch the needle before it touches the patient. Just make sure it's on there nice and square. I put that down, get it ready. I've got my 1% lignocaine, 10-20-20, so we can use 10 mils of 1% at 50 milligrams per mil, up to 10 mils on PGD. Any more than that, you'd have to weigh the patient, and it would be 3 milligrams per kilo. So I'm going to pretend to infiltrate. I've got my 5 mil syringe, I've got my green needle, and I'm going to infiltrate. So the proper technique to infiltrate is to use the wound that's already there. So I've got my 5 mils of 1%. I'm not going to go in on the outside and poke holes on the outside. I'm going to use the wound that's already there, and I'm going to go in the side. I'm not going to bend the needle. I'm not going to touch the needle. I'm going to go in the long side of the wound. I'm going to pull back, making sure that there's no blood coming back up into the syringe, because I don't want to be in a vessel, because I don't want to be putting lignocaine directly into a vessel. And then I push in while I withdraw the needle ever so slowly. And I do the same thing all the way up the side of the wound. So I withdraw back, no flashback, I carry on and infiltrate while I pull back the needle. And I do it all the way up both sides. Again on this side, making sure. So I continue to go up, put a wet piece of gauze over that, have the chat to the patient about how they got their wounds, wait a couple of minutes, and then ask them to look the other way and just gently poke the side of the wound to see if they can feel anything sharp or dull. And if they feel something sharp, just make sure that you go back in, withdraw, and put a little bit more lignocaine in where they feel sharpness. It's okay that they feel dull as long as they don't feel sharp. And then once that's all done, you get rid of your sharp. I always put my sharps in there. So I've got my toothed and my non-toothed, and I've got my scissors. So because this is a wound that's happened during trauma or being hit or falling over, I'm going to start in the middle of the wound, because unless it's a surgical incision done in surgery where they will incise and then to stitch up, they will always start in the corner and work their way across. But because this is trauma and we want to make sure that the jagged edges come together, we've given it a good clean. We're always going to put our first suture directly in the middle of the wound.